mentioned that both Dr. Avery and Dr. Svec have no financial relationships with ineligible companies to disclose. So with that, I will let Dr. Svec go ahead and get started. Oh, you're gonna start, okay.
So good afternoon again. We call it's this one, right?
Yeah.
So these are the objectives for this afternoon's talk. We'll describe current CDC recommendations on physical activity for health and weight loss, identify abnormal physical changes in patients with overweight and obesity, develop physical exercise recommendations, identify patients who are in need of exercise stress testing, and develop an exercise prescription. Okay. So let's first start with the definition of obesity. So this is the Obesity Medicine Association's definition of obesity. Obesity is defined as a chronic, progressive, relapsing, multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biomechanical, and psychosocial health consequences. It's a very long definition, but it encompasses everything that happens with a patient with obesity. So there are two things that happens with a patient with obesity. There's deranged endocrine and immune responses, and there's also abnormal and pathologic physical forces. So the sick fat disease, SFD, or adiposity, this will result in elevated blood pressure. So there's endocrine and metabolic derangement. So their blood pressure increases, the glucose increases, there's cholesterol that will increase, and other metabolic disease. In the fat mass disease, there's biomechanical and structural, meaning because there's a lot of mass. So there's stress on weight-bearing joints, immobility, there's tissue compression, sleep apnea, GI reflux, high blood pressure, and tissue friction. So there's impetigo, and then there's also a lot of infection in the skin as well. So there's gonna be postural changes in obesity as it results with it. So excess mass puts stress on joints. So it brings more weight to knees, hips, and spine. Excess weight also creates abnormal mechanics on body movements, increasing the musculoskeletal disorders. So there's going to be pain, osteoarthritis of the knees, the hips, and the spine. There's decreased mobility and balance as well. And the center of gravity of the patient shifts forward. So because there's a lot of weight now in front. And so then they will have to kind of like balance themselves, either leaning forward or going back. So look, there's going to be lumbar lordosis and increase it with the pelvic forward tilt. And then also there's internal rotation of the hips. And then genivalvus deformity and flat feet are also common, where there's kind of be like that. So where the knees are locked in together, the feet is also splayed apart during standing to optimize the center of gravity and stability for them to balance themselves. So there's a lot of changes when there is obesity. So for weight management, three things has to happen. There has to be behavioral therapy or behavioral changes, dietary changes, and physical activity. So there's also now a lot of medications that have been approved, FDA approved, and also with bariatric surgery. However, without the behavioral change, the dietary change, and physical activity, pharmacotherapy and bariatric surgery, they're not going to be effective. So going into the importance of physical activity. Physical activity is important with weight loss. It's the burning of the calories through physical activity combined with reduction of the number of calories that you eat creates a calorie deficit that results with weight loss. But it is also important in the weight maintenance. So once you've lost the weight, it is important to have physical activity to actually maintain the weight loss. Evidence shows that the only way to maintain weight loss is to be engaged in regular physical activity. And this is the National Weight Loss Registry Program It actually tracks patients who have lost about 40 pounds in their life, and almost all of the patients that have lost that weight are engaged in physical activity every day. So aside from the maintenance of weight loss, there's also reduction of the risk of cardiovascular disease and diabetes. And this decreases the risk beyond that is produced by the weight reduction alone. So how much physical activity do I need, right? So there's different types of physical activity. There's the dynamic or aerobic training, which would be at least 150 minutes or 2.5 hours per week of moderate physical activity, or at least 75 minutes per week of vigorous intensity aerobic exercise. So this usually has the most health benefits and promote modest weight loss and prevent weight gain. You could also do more than 300 minutes or 5 hours per week of moderate physical activity, or 150 minutes per week of vigorous intensity aerobic exercise, and this promotes more robust weight loss and prevent weight regain after the weight loss. We also have the anaerobic strength training. So this utilizes appropriate weightlifting technique. So this emphasizes the core muscle exercises. So the core is the midsection of the body. The muscles relate to the abdomen, back, the hips, important for posture and balance stabilization. And using a variety of free weights, machines, and resistant bands, you can elicit the less boredom and provide greater flexibility regarding scheduling and location as well. So for patients, they want to be able to be flexible for that. There's also what we call the NEAT, or the non-exercise activity thermogenesis, which is both transportational or occupational. These are activities that you can do without doing exercise. Like, for example, going up the stairs instead of the elevator, using standing desk instead of using desk that you have to sit down on, taking the stairs, parking far from the building, instead of, like, when you're watching TV, instead of just sitting and watching TV, you can fold clothes, or do something so that you are increasing your physical activity. So that's what we call non-exercise activity thermogenesis. So this slide kind of tells us the greater benefits with more steps per day. So there was a study 2 years ago that came out about the health benefits of 10,000 or more steps per day on cancer risks and cardiovascular disease. So if you get, as you can tell, when it reaches 10,000 steps per day, the benefit plateaus. So as long as you have reached 10,000 steps per day, then you're good. So, but that's how the study shows. So 2 years ago, it came out in 2022. There's another study that came out which have the same results as well. So this is a pretty good way of, when we are advising patients, it's something that I would show them. I would show my patients this chart. So when you advise physical activity to your patient, there are some, I kind of divided it into 4 groups. So there would be a patient that would say, no, doc, I'm not interested. So what do? So you say, well, you can get up and walk around at least once every hour or once every 2 hours, right? So but there's also some patients who would say, yeah, I hear you, but I'm not exercising. You can advise maybe 5,000 steps or 10,000 steps per day and use the stairs when possible, because the word exercise, they're allergic to it. So they really don't want to do exercise, but at least you can advise the non-exercise activity thermogenesis. There are also other patients who would say, yes, I'm willing to exercise and I will try it. So then you can advise the 150 minutes per week of walking, 75 minutes per week of jogging, or 100 minutes per week of brisk walking. You can also, if there are patients that would say, yes, I'm all in. So then the best, supposedly, like the literature is now coming out that the best exercise for weight loss is the high intensity aerobic exercise, or the HIIT, which is the high intensity interval training plus weights. So it's the best is if you combine both cardio and resistance exercise. So those are for patients who are really into it. So we can have that. I think I'm gonna call Dr. Svec because it's his turn.
All right, so then typically this is how I start when Dr. Avery refers them over to me. So these are like physical activity level questions. Sometimes people will call them additional vital signs. There are some organizations like I think Kaiser, they'll actually include this in their rooming of the patients. So on average, how many days do you engage in moderate to physical activity? For example, brisk walking, bicycling, aerobic dance, and on average, how many minutes do you engage in physical activity at this level? A lot of times, I don't ask specifically like that. I kind of keep it more general, like what are you currently doing to exercise? A lot of times it is just the NEAT, I walk around a lot at work. I try to take the stairs, and there aren't a lot of minutes that they dedicate to actual exercise. And then I'll also ask them what their past exercise is. So what have you done in the past? Sometimes maybe they've just kind of like fallen off and they were more active before, but now they're not really doing anything. So this is the health screening. So knowing kind of what, I know it's probably small, sorry. But knowing if you should be concerned or not about guiding people towards exercise, and this is put out by the American College of Sports Medicine. They have a pretty big initiative called Exercise Medicine. So they're trying to encourage physicians and healthcare workers to encourage their patients to exercise. They kind of just follow the flow chart along. So do they exercise regularly? No. Then you kind of want to see if they have cardiovascular, metabolic, or renal disease. Depending on the severity of that, depends on whether they really need cardio, or not just cardio, but medical clearance before they can start exercising, or whether you can just go full into guiding them to exercise. And so that's usually a good place to kind of figure out where we're at. And then some additional questions I asked. So I mentioned the past exercise history already. I do also kind of want to know like what resources I could work with when I start to like counsel them to do exercise. So whether they have any gym memberships, whether they have equipment at home. It's surprising how many people have gym memberships and equipment at home that they don't use at all. So that's always a good starting point. So saying, well, why don't we use these things you bought? And then we get to actually making up the exercise prescription. So pretty much, I think everywhere you're going to read about exercise prescriptions, they mentioned the FIT acronym, FITT, so frequency, intensity, time, and type. And so I'll go step by step through those with the patient. So when I made the presentation, we'll go step by step with y'all too. So with frequency, I like to set realistic goals with them. Ideally it's 150 minutes a week, which you could divide into 30 minutes a day, 5 days a week. But people that are doing 0 days a week, it's kind of not realistic to assume they're going to go from 0 to 5. Some people, the very motivated people may, but for the 0 days a week exercise, I usually say, let's start with like 2, or let's start with 3, something that is more achievable. And then when they check back in with you and they've been meeting the 2 or 3, you can applaud them for meeting that instead of saying, oh, but you're still not at 5, because that's really discouraging when you're trying to get people to increase their physical activity. So first is frequency. That's kind of how I go about doing it. If they are already doing 3 days a week, then sure, I'll say like the goal is by the next time you see me in a month or 2 to be up to 5. Intensity. Most of the time I pick this part for the patient. I don't do this more as a group activity, and this I base on their prior physical activity and also their medical history. So someone with pretty significant cardiovascular history or renal history, I'm gonna stick towards the low intensity, maybe do some moderate intensity. And I kind of listed some examples of what each of those would be there, because when you read about it, it's very vague, and sometimes it's calculated based on the heart rate range you're in, but to me, that's a little too complicated. So here are some examples. So low intensity is like slow walking, shopping, household chores, strength training. So strength training can go between low and moderate, depending on, you know, the weight levels that they're at. So low weights, probably lower intensity. Moderate, you know, brisk walking, cycling, swimming, doubles tennis, line dancing, and then also, like I said, strength training can kind of go between the two. And then vigorous jogging, running, swimming laps, singles tennis, rollerblading, basketball, football, jumping rope. Because those, if you think about it, the vigorous ones are all the things that are going to get your heart rate up significantly. So instead of doing the calculation, to me, this is a better way to kind of guide. Most of the time, with the patients I'm seeing, I'm doing low to moderate to start. Time, so same thing, I base it on what they're currently doing. 30 to 60 minutes per day is the goal, but again, like 0 days, if they're doing 0 minutes, we want to start at the lower end. So 20 to 30 minutes if they're not doing any. Also, if they're limited by their history, like they have bad knees, so too much walking will hurt their knees, splitting it up into 2 separate sessions of walking to still get to the 20 to 30 minutes. I encourage that a lot because they're like, oh, I can only walk, you know, 5 minutes. I'm like, okay, well, let's walk 5 minutes 2 to 3 times throughout the day, maybe do some strength training mixed in. So that's how I usually pick time. And then type. And this is where getting like, do they have gym memberships? Do they have exercise equipment? All those things come in. Because I hate telling people that they have to buy a lot of things. And so I try to use what they have. And if I do tell them to buy things, I try to keep it on the cheaper end. So a lot of times I pick walking, unless they really can't walk, knee arthritis, ankle arthritis, an issue like that. If they have access to a pool, a lot of times I'll adjust to swimming, especially for those with the significant arthritis. And then resistance bands is where I'll start for someone that doesn't have a gym membership, doesn't have dumbbells, doesn't have, you know, a weight machine at home, which most people don't. Because you can get them for like $25 on Amazon, and you can get a whole set with varying degrees. So even if they are real consistent and they progress out, you know, they can move up in terms of bands that they use. And then also the intensity level, you know, you want to use that too. You don't want to tell someone that low to moderate intensity and then tell them to go swim laps. So, and then that's the last part. So then usually I'll put all that together. And there are some pre-made prescriptions. Exercise Medicine is a website, actually. I think it's exercisemedicine.org. And they have some pre-made things you can actually fill in and sign. Typically what I do is we have Epic, and so I'll put it into the after visit summary, and I'll make it very big. And that way they can actually put that front page of the after visit summary like on their fridge or on their mirror or somewhere that they will see it frequently and be reminded that these were the goals we said that we were going to do. A tricky part of this can be billing. And so typically like a code like obesity really can't be billed by itself. So some of the ways that you can is include it as a part of an annual physical. So, you know, exercise promotion definitely fits within an annual physical. You can bill for time, and then you can also talk about how it can help with other chronic conditions. And that's what I do a lot of the time, because when you say that exercise for weight loss, sometimes it's not as motivating as if you say, well, this is going to help with your blood pressure, and this is going to help with your diabetes. This may help with your overall mood. Those are all things that exercise has been studied to show that it does improve. And so I try to tie in everything and not say you're just doing this to lose weight. So, and then next, it's a lot of pictures of me, sorry. So we were gonna go over some of like simple exercises. You could show some activity limited people. I don't know, Dr. Avery, how do you want to do it? Do you just want me to do pictures?
There you go.
Yeah.
That's what this cheap.
They went in,
Demonstrate, like,
they went in here to like.
okay.
That takes, I think, a clock. Oh, on the page. Do you want me to put the chair up there?
Well, can't be.
All right, so I will say most of the things we put in here are very, very simple, so they would apply to the significantly activity limited people. So first we have ankle pumps. So it's actually two different ways to do it. Typically I'll tell them, you know, to it's like you're stepping down on the gas or raising the back of your foot. So that's one way. And then the other way is to raise your toes. And so you're doing two different types of exercises there. You are, you know, pump ankles is kind of like a generic way of saying, the way I look up these slides, I should have said that. The top is kind of like what we're doing, alternating plantar flexion versus flexion. Obviously, we're not going to tell patients that. So pumping ankles is the way to phrase that. And then, you know, 3 sets of 10 would be a good starting point. You can go up to 5 sets, you can change repetitions, 12 to 15. So, speed and march. And so this one you want to tell them to, you can say raise your right arm and your left leg, switch. Obviously, if they're not so limited, they can do a standing march, they can actually walk around the room. But it's opposite arm, opposite, or the leg is opposite, so not like that. And then that one, really repetitions doesn't make sense, so 2 to 3 minutes. You can increase minutes, so, you know, 5 to 10, 10 to 15 for people that are a little bit more active. Leg extension. And so here, you just tell them to straighten up your leg. So, and that's a good exercise for the quad. That can help with knee pain and things like that. If you're strengthening the muscles that support the knee, that can help the knee have less pain. A lot of times, things like this are in physical therapy. If that hurts them, an alternative is they can lay down and do just straight leg raises. So instead of there being motion at the knee, motion at the hip. So you want to do this on both sides. So they can either alternate sides, or they can do the 10 repetitions on one side and then switch to the other side. Whatever, it doesn't, that part doesn't really matter. And then we have shoulder shrug. So we move up now. So this one you want them to be seated, good posture. So you want to make sure the back is straight. And then tell them that they're trying to touch their shoulders to their ears. And then I think I forgot to mention this on the leg sentence, but you can add a hold in. So, because just doing this might be easy, but you know, doing this and holding, you actually are working the neck muscles and some of the upper back muscles. Let's see. This one you can't see, so I added like a little picture to it. And you probably won't be able to see it with Dr. Avery either, so I'll just talk through it. So you're trying to pull your shoulder blades back and down. One thing that sometimes helps is you can tell them they're trying to pinch the pin between their shoulder blades, and that kind of gives them guidance. You don't do this. It's weird, and you may just not have like the neuromuscular control is good, so things like food can help. There's a good chunk of this that comes from just like the personal training world, but I'm not that. So 3 sets and 5 repetitions, the same thing, you can put all those in here. Here we have pelvic tilt, so. So you're trying to tilt the pelvis forward and pull. And this is another one where if you don't have the muscular control, it could be difficult to do. But just you're basically telling them to try to contract their core and their low back muscles, and it should kind of get them into the position. So and then you want to make sure the back is straight and the shoulders are back throughout most of that. That posture during exercise is usually not a good thing. And then last, we have walking. So, you know, just walking in place, walking around the neighborhood, walking around the house, anything important. I just mentioned these things, like keeping the back straight, shoulders back, stepping heel to toe. So 10 to 15 minutes is a good starting place. Obviously, that one you can just increase minutes. And then the last few slides, we won't be able to demonstrate because they require resistance bands. But I wanted to show some of the things that you could tell people to do as resistance bands. So there's 4 exercises in there. Very straightforward. So this is a standing row. You can do it standing or seated. And so basically stand up straight. Another one where you're going to keep the shoulders back, and they would just grab the handles and then pull back. And they want, I'm going to put this down for a second. And you want to try to keep your elbows close to the body. You don't want them to be going out like this or out like that. Elbows close to the body. And that scapular retraction we did, that helps with that control. So. And then you can leave the anchor in the same place. So I'll explain that in a second, sorry. And you can do a chest press. So you just spin around and push out. And it's like a bench press, but standing. It's also a little less scary than a bench press for people that don't exercise. And 3 sets of 10, you can do it seated, you can move down. When I mentioned anchor, I meant to say the thing I'm using here in this picture is a door anchor. And so you put it on the hinge side of the door and you just loop the resistance band through it. And then it lets you do a bunch more exercises with resistance bands. Because a lot of people are familiar with them in terms of like standing on them or just pulling them apart. But this kind of adds some more things you can do. Here is tricep. So tricep pull down. So I move the anchor up on the door, and you're just pulling straight down, and that works out the tricep. Again, keeping the elbow close to the body. And then last, you switch. So you put the anchor as far down as you can, and you do a bicep curl. So, and most people know curls. So, but if they don't, stand straight, grasp the handle, and pull towards your face while keeping the elbows close to the body. So that's just important because it helps isolate that muscle. If they start pulling their elbow forward, they're actually recruiting other muscles. And so those are just, you know, some easy intro points we have. I have a little slide here. These are the resistance bands that I was actually using in the pictures. And so it's on Amazon. I think it's called like Black Mountain Products. And it comes with those 5 bands, a little bag, the handle, and the door anchor. And it's like $25. So I never feel bad telling patients, oh, it's this $25 thing from Amazon. And everyone has Amazon. So and then this is kind of just like promoting the physical activity in your clinic. So put up flyers promoting exercise medicine. The one in the corner is actually from that resource. You can see it down the little green text, exercise medicine, ACSM. Included in your after visit summary. You know, you could staple that page to an after visit summary so they kind of see it. Start your own walk with a doc program, which Dr. Avery has. Encourage well-being in your healthcare team. So, you know, a lot of times you'll see offices will do weight loss competitions or step competitions and things like that, which is good. It's encouraging well-being in that office. And then walk the talk. So I do go to the gym, and so I don't feel like a hypocrite telling people to go to the gym or to exercise, and so, you know, taking care of yourself is just as important as telling them to take care of themselves, and so, and they're more likely to listen to you when we talk about things, and I'm like, oh, well, when I'm at the gym, I do this, and I think they appreciate it. So, and I tell them, you know, well, I started here, so then they don't feel so discouraged and things like that. And that was everything I had. Here's our references. And then I think it's a question. I don't know if Dr. Avery wants to come up because I can't answer the obesity medicine one she had at the beginning. Any questions? Dr. Avery.
Your experience with your walk.
Yeah, so the Walk with the Dog program, this was because of sponsorship from the AMA. I started it, well, it took a while to get it approved through legal, and marketing. I started it July of 2022. I would walk with my patients every second Saturday of the month at the Obish Naval Park. It's about a 2-mile walk, so everyone is invited, it's not just my patient. But it became a clinic event, meaning that it's not just me, the MAs are there, our LVN is there, other members of the healthcare team are there. And then the patients love that because when the patients come and see like, oh, it's with, you know, Dr. Avery is there and then the nurses are there as well. I also invite the medical students that are involved with Frontera de Salud. So they come, sometimes they would bring their equipment to do health screenings. And so some patients like that as well. Yeah, and it has been a really rewarding experience because you get to talk to your patients, not just about, and see them not inside like in the four corners of your clinic, but you see them somewhere where they're bringing their family, they bring their kids, they bring their daughters, they bring their fathers. One of our doctors that I had invited before, I think some of you know Dr. Richel Rodriguez. She's one of our regular walkers. This was the first time that I met her father, and her father has become a regular walker as well. And so that has been, not for me, it has increased my well-being as a physician, that I'm doing something, and then at the same time, I'm helping the patients improve their health, and it also helps me as a physician. So that has been my experience with that.
It's also YouTube video. And it's animated. I worked out. For research, all the value. Anybody can write down can create a go home and watch videos. It's fun.
I can repeat. Sorry, I should have thought about that sooner. So he was saying there's a YouTube video called 23.5 hours, that was put out by a cardiologist that researched the value of 30 minutes of exercise a day and all the benefits from it. And so he likes to encourage patients, I'm guessing, to go there and watch those video or watch that video. It's very good and compelling.
I think doing it yourself is probably the most do this 7 days.
Yeah.
Yeah.
One thing kind of pivoting, there are things that I've thought about this, because this is something that we would, I see patients do in the clinic. but which is not proper when they're trying to stand. And I want to share with you, you know how some patients would like, oh, they have knee pain, right? And then they started like doing this, which is bad. So advise them always to lean forward so that their weight is forward. So like when they stand, so like to lean and then their body is here and then stand like that. So not like this. So then they're, so just kind of like to share that because I see that a lot in the patient. And it adds more injury.
If you're traveling, you don't have your equipment, you take off your equipment, there's no, 7 minutes. There's another one called 7-minute workout, only you chair, and you can do it with recovery, and, so it's something you can do in literally 7 minutes, and it'll keep you from skipping a day in the afternoon. You can, it's totally ability based. In other words, maybe you only do, 10 jumping jacks or something, or 2 or 5, whatever. It's 1 minute for each exercise, and it's set exercise. So you may do your planks on your knees instead of on your toes. So it's very, you can individualize the patient. It's called 7 minutes, and they can do it anything.
I think I have that app too. Yeah, my 2-year-old love. I have a question. So once you prescribe exercise for the how close do you follow up with it? How close do you recommend someone with that?
So it varies, if they're only seeing me, if they're only seeing me, I'll do 4 weeks. If they're a part of Dr. Avery's program, a lot of times I will give them the option to either follow up with me in 4 weeks or to follow up with Dr. Avery. Just because the weight loss program involves visits with Dr. Avery, visits with the dietitian, visits with behavioral health. I also don't want to overburden with appointments. And so if they follow up with her and maybe they've gotten off track, she can always encourage them to come back and see me and we can refresh. But I don't want to do too much because then that's also overwhelming and keep up with it. I don't know how frequently do you think they stick with you? I think a lot of the time, right?
Yeah, they do. One of the things is that I see more patients follow what you tell them if you actually have them demonstrate, like return demonstrate. Like, okay, how would you do it? So like even not the weight loss patients, like those patients that we're trying to help them the stretching or like some piriformis issues that they have and want to have them stretch the UPL muscles. So for those, if you have them actually return them, maybe it would take you about 3 minutes there in the clinic. It helps them more so because they know that, oh, the doctor is really serious. And I have patients that return to, oh, that really works. The stretching of the calf muscle that you have you demonstrated that really works. So that helps a lot if you not just tell them, yeah, do this, but you actually teach them how to do it and then let them do it.
That's your patient population. Don't let them hurt themselves. The most injurious thing to the program is let them get hurt. But then they don't want to do this. So that it's not ridiculous to go what appears to be ridiculously slow in terms of the benefit. Don't let them get hurt. Because once they get strained, tendon, anything, they're going to suffer. So go super slow. It may take you a year to get them up to covering a mile and a half to 30 minutes. Doesn't matter. Just start really slow.
Excellent point. Thank you.